Hello, my name is Cristina Perez Gallardo, and I'm an occupational therapy student at Texas Women's University. Today I'm going to be conducting a hand examination, which is going to consist of primarily three parts. First, I'm going to do an observation of the upper extremities. Second, I'm going to check range of motion. And then lastly, I'm going to conduct specific assessments for hand pathologies. Before we begin our observation, it is essential that you get a thorough history on your patient. Getting information such as whether or not they've had past surgeries, whether they have any injuries, or any acute or chronic situations that they're currently facing. The next thing we're going to be doing is starting our observation assessment. So when observing the upper extremities, you want to just make sure that you compare both extremities together. With that said, you want to just look out for the muscles and make sure that the muscles have a normal appearance. Other things to look out for are color, making sure that there isn't any bruising, any whiter areas, or any areas that have more color like red. Also, you want to just make sure that you look out for swelling. Are there any areas of the muscles, of the joints, that may look swollen, which may be indicative of some pathology? And the last thing you want to look at is the joints. So you're looking here at the DIP joints, the PIP joints, MCP joints, your wrist joint, which is a radial carpal joint, and then your elbow joints and things like that. So it's important to make sure that your patient comes in with a short sleeve. If not, then you can have them lifted up so that you can observe the upper extremity. Another thing, once you do your observation, another thing that is important is checking the pulses. Now, the pulses can be checked in three areas of the upper extremity. So we can do the radial pulse, which is right about here. Okay. Then you can do the ulnar pulse, which is right about here. And then you can do the brachial pulse, which is right about here. It's really essential that you check the pulses before you begin any range of motion or any specific assessments. Once you do the radial, ulnar, and brachial pulses, it's important to also check the capillary refills. This can be done by just blanching the nail bits here and seeing how long it takes for the capillary refill to occur. Normal refill is about 2 seconds, and anything that's prolonged after that can be indicative of some sort of problem there. So just making sure that you check your capillary refills on the patient. Hello, so now I'm going to be checking range of motion. Okay, so the first thing you want to do is have the patient be able to take their thumb and touch their ipsilateral shoulder like so. This motion is primarily occurring at the elbow joint and its elbow flexion. The next thing you want to do is check pronation and supination. This is done by having the patient bring their arms close to their side and then have their palms facing up on the table like so. The examiner can then come and then pronate their arm and then supinate their forearm. And they can do the same thing on the other side. You can pronate the arm and then supinate the arm. And it is important that you make sure that you compare both extremities with each other. The next thing that you want to do is also check for wrist flexion and extension. This can be done by having the patient place their elbows on the table just like so, and then flex their wrist and extend the wrist. So here you want to make sure that they're able to do it and also check to see if the range of motion is within functional limits. The last thing you want to do is check for digit motion. And this can be done by having the patient flex their fingers to see if they're able to get it and flex it to the distal palmar crease of their volar side of their hand. Once again, you want to make sure that they can flex their fingers to the distal palmar crease of each hand. The last thing you want to do is check thumb range of motion, and this is done by having the patient kind of reach over and then touch the fifth metacarpal head, just like so. So now I'm going to be conducting assessments for tendinitis. First, we will start at the elbow. If you suspect that there's tendinitis, you first want to make sure that you isolate the tendons that seem to be the problem. Here, we have the lateral epicondyle. Most of the wrist extensor muscles and the superficial layer originate from this area. Here, we have the medial epicondyle. Most of the wrist flexors and the superficial layer, as well as the pronators, originate from this area. So the first thing you want to do is just have your thumb here on the lateral epicondyle and have the wrist extended here. You will ask the patient to resist, and if there is any pain that is elicited here at the lateral epicondyle, this is an indication of lateral epicondylitis or tennis elbow. Now we will test medial epicondylitis or golfer's elbow, and this is done by doing the same thing, just holding here at the medial epicondyle and then asking the patient to resist while you try to extend it and pronate at the same time. If there's any pain here at the medial epicondyle, this is indicative of medial epicondylitis or golfer's elbow. So now we will be testing tendinitis at the wrist. On the wrist, we have 6 main extensor compartments. The first compartment is right here, and it houses the adductor pollicis longus and the extensor pollicis brevis. The second compartment is right about here, and it houses the extensor carpi radialis longus and the extensor carpi radialis brevis tendons. The third compartment right about here is the tendon that runs alone, and that's the extensor pollicis longus. The fourth and middle compartment houses the extensor digitorum communis and the extensor indicis tendons. The fifth compartment here houses the extensor digiti minimi tendon alone. And the last and final compartment, which is compartment 6, houses the extensor carpi ulnaris. The areas that are most common to get inflamed are the adductor pollicis longus and the extensor pollicis brevis that are located here in the first compartment at the wrist. Now we will perform the Finkelstein test. This is performed by having the thumb flexed and the fingers closed while the patient ulnar deviates the wrist. If pain is elicited here, this is positive for Finkelstein. So now I'm going to be testing for intersection syndrome. Intersection syndrome typically happens here, where the first and second dorsal compartments of the arm intersect. In order to test this, you must palpate here and then apply resistance to the extended wrist. Any pain in this area is positive for intersection syndrome. Now, when testing or examining the flexor carpi radialis or the flexor carpi ulnaris, we will first start with the flexor carpi radialis. Here, the wrist is flexed up, and then you apply resistance on the radial side and look at the radialis tendon. If there's elicits a painful response, this indicates problems with the flexor carpi radialis. You will then do the same thing to test the flexor carpi ulnaris tendon. Since it runs along right about here, you will be here and then you will add resistance while the wrist is flexed and slightly ulnarly deviated. A painful response here at the ulnar flexor carpi ulnaris is indicative of problems or tendonitis in this area. Now we're going to be testing the PC triquetral for arthritis. This pain will be elicited with ulnar deviation and flexion while palpating the PC and triquetral area right about here. Now we're going to test for the flexi carpi ulnaris as their head runs to the ulnar side right here. And this can easily dislocate. To test for that, you supinate the forearm and you extend the wrist. And you feel just right there. So now we're going to test for the extensor pollicis longus. The extensor pollicis longus runs right about here and inserts here on this ulna. Runs to the Lister's tubercle. Resisted thumb extension while palpating in that area will elicit response. So I will palpate here, and then I'm going to apply resistance, and she's going to have to resist me. Any pain right here in Lister's tubercle is indicative of the extensor pollicis longus problems. So now we're going to take a look at the wrist and the carpal bone anatomy. The carpal bones are aligned along the wrist in two rows. Here's a proximal row and here is a distal row. This row here articulates with the distal radius in the ulna at the radiocarpal joint, and the distal row here connects with the proximal row of carpal bones at the radiocarpal joint. So now we're going to go over the carpal bones. Here we have the scaphoid, here we have the lunate, here's the triquetral, and here's a projected pisiform. Here we have the trapezium that connects with the thumb. Here we have the trapezoid, the large capitate, and then lastly the hamate. These bones and the joints at the wrist are extremely helpful for flexion and extension, and helpful for partial radial and ulnar deviation. So next we're going to take a look at the carpal tunnel. The carpal tunnel is located in this area, and the following carpal bones, such as the pisiform, the hamate, the scaphoid, and the trapezium, create the borders of the carpal tunnel and are the areas in which the flexor retinaculum connects to. The following structures that enter the carpal tunnel before inserting on the digits are the flexor digitorum superficialis, which divides into 4 tendons and inserts on the base of the middle phalanx, the flexor digitorum profundus, which also divides into 4 tendons and inserts on the base of the distal phalanx of digits 2 to 5, and then lastly, the flexor pollicis longus of the thumb, which also comes to the carpal tunnel and inserts on the base of the distal phalanx of the thumb. One major thing that also comes to the carpal tunnel is the median nerve. So a common median nerve compression of the carpal tunnel here is known as carpal tunnel syndrome. This can be tested by the median compression test, where the examiner will compress the median nerve here and ask the patient to flex the wrist to provoke tingling and numbness at the thumb, pointer and middle fingers, and on the radial side of the ring finger. Any numbness or tingling is indicative of carpal tunnel syndrome. Another carpal tunnel test is known as the Phalen's and the reverse Phalen's test. The Phalen's test is done by having the patient flex their wrist while both dorsal sides are touching each other for approximately 1 minute. If tingling or numbness is elicited, this is positive for the carpal tunnel syndrome. This test is called the Phelan's test. The reverse Phelan's test is also used for carpal tunnel, and it's the opposite of the Phelan's test, where the patient has their hands in a praying position for 1 minute. Numbness and tingling will also be indicative of carpal tunnel syndrome. So next we want to take a look at the Gaynes Canal, which is located right here on this side, and it enhances the ulnar nerve and ulnar artery, as well as the tendon of the flexor carpi ulnaris. To test for ulnar nerve compression at the Gaynes Canal, we will perform the Tinel's and compression at the ulnar nerve, just like so. If positive, the client will experience tingling or numbness at the ulnar and radial side of the 5th and ulnar side of the 4th digit. This is the ulnar compression test. Now we will take a look at wrist instability. We will do the Wotton scaphoid shift test for scaphoid instability. We first place our thumb at the scaphoid tubercle, right about here, while going from ulnarly deviated to radial deviated and pushing on the dorsal tubercle. Any popping will be indicative of scaphoid instability. Now we're going to talk about sensation. A common test is called the 2-point discrimination test. This test is typically done by applying 2 points or 1 point at the volar side of the distal phalanx of the hand. The examiner can use either a discriminator and or a paper clip that's approximately 5 to 8 millimeters apart. In this case, I have a paper clip here in which I'm going to apply to the hand. So essentially what the examiner does is they apply either 2 points or 1 point, and the client must discriminate whether it's 2 points or 1 point, and that is a static test for 2-point discrimination. The examiner can also do a dynamic test in which the 2 points or the 1 point on the discriminator or paper clip are rubbed along the fingertips of each finger. And it is important that when you are conducting this assessment for sensation, that on the ring finger you test both the radial side and the ulnar side, since that particular digit is innervated by 2 different nerves. Another thing that is essential to look out for is testing reflexes. So you typically want to test reflexes. You want to do your biceps right here, your brachioradialis here at the insertion at the radial styloid, as well as your triceps here on the olecranon. Another thing you need to know is the ulnar nerve runs around the medial epicondyle right here, and then it just comes to the cubital tunnel and splits between the flexor carpi ulnaris right about here before going to the digits at the hand. Ulnar nerve entrapment can typically happen halfway through the humerus up here and about 6 centimeters distal to the elbow right about here. When a person has cubital tunnel syndrome, they will have difficulties with elbow flexion, and also tingling and numbing, or with tenal sign all along the ulnar innervation aspect. They may also manifest clawing of the little and the ring fingers of the hand, which is basically characterized by hyperextension of the MP joint and flexion at the IPs. Next, we will test the thumb and the index pin strain. This is done by grabbing a paper or a card and having the client hold it in between like so. The examiner is going to pull the paper like so. If the client keeps their finger straight, then it is fine. If the client either flexes their thumb and cannot hold this, then that's indicative positive for Foreman sign. Another thing you need to look out for is Wartenberg sign. This is when the patient is not able to adduct their little finger towards their 4th digit like so. So if If they're unable to do this, it is called Waardenburg sign. Also, it is important to know for median nerve compression, thenar atrophy can occur right about here. And the adductor pollicis brevis is weak, and the client will manifest difficulty in performing opposition, just like that. Another important test for the carpal metacarpal arthritis of the thumb is called the grind test. Essentially, how you do this is the thumb metacarpal is grinded on the trapezium like this. If the patient has any pain or swelling, the test is positive. Now we can take a look at the flexor digitorum superficialis and the flexor digitorum profundus, which come to these 4 digits here. To test the FDP, we need to grab each individual finger like so and see if the client can flex at the DAP joint, just like this. Now, when we want to take a look at the flexor digitorum superficialis, it is important that we isolate all the other muscles because the FDS inserts here and can help. So we want to see if she can flex at the PAP joints like so. Okay. Again. Perfect. Okay, again. Very good. Now we're going to talk about radial nerve injuries. When a radial nerve is severed, it will cause a wrist drop because the radial nerve innervates all of the wrist and extensors, all of the wrist and finger extensors. To test for radial nerve palsy, you want to see if the client is able to bring the wrist up, and also to see if they're able to bring the thumb over the second digit, just like so, without substitution. In addition, to test the extensor digitorum communis, you want to make sure and see if the patient can flex the IPs while keeping the MCPs extended like so. Okay. Lastly, we will talk about common deformities, such as boutonniere finger, swan neck, and mallet finger. Boutonniere finger is characterized by flexion of the PIP joint, like this, and hyperextension of the DIP joint, just like this. Mallet finger is characterized by flexion of the DIP joint, just like this. And then swan neck is characterized by hyperextension of the PIP joint with flexion at the same time at the DIP joint. All of these deformities can occur by trauma and or by degenerative diseases such as rheumatoid and osteoarthritis. This concludes our hand examination video. Thank you for watching.